All right, well, let's get started. Thank you again for your time this morning. This is Matthew Menendez with White Plume. This webinar is designed for physician practices, and we're going to be talking about what to expect with ICD-10 in 2016. So let me go through just the agenda real quick of what I hope to accomplish today. The first thing, and this may not be something that you have a question of in your mind, but you may have doctors who do, or you may have other people in your organization who would say, why in the world are we still talking about ICD-10 in 2016? I thought that was something that we did last year. I thought that was behind us. Unfortunately, we know that that's not true, but I do want to address that because I do get questions on that, and I think that's a helpful place to begin. So we'll start there, and then we're also going to look back at 2015. What went well? What was the good news? What was the bad news from 2015? And then how can we use that to try to predict what will happen in 2016? What's the outlook? What are the risks out there for physician practices? I think the big two that are still out ahead of us are, number one, physician productivity. If our doctors are not taking care of patients, nobody else is. If our doctors are not generating revenue for the practice, nobody else is. And if our doctors aren't happy, right, nobody else is. We've got to make sure we protect their productivity, right? That's first and foremost. At the same time, we have to counterbalance that with the revenue cycle need to make sure that we get the right codes, that we jump through the hoops that the payers put out there so that you can get your claims paid completely and correctly the first time, right? Because if we can't continue to convert our patient encounters into cash, that becomes very bad very, very quickly for the practice. So that's what I want to make sure that we cover. We'll talk about some strategies about how to do that, and I'll make sure that I leave time for questions and answers at the end. So for those of you who are just joining us, welcome. We just started, so you haven't missed very much. Go ahead and take a quick second to locate the questions panel. Should be on the far right of your screen. I'll try to answer as many of those questions as I can at the end of the webinar today. So that's what I hope that we're able to get through. And what do I hope that you'll be able to take away? Right? Let's start with the end in mind. What will you hopefully learn over the next 50 minutes? That the first thing is that October 1st was the starting line for ICD-10, not the finish line. Right? We started using ICD-10 on October 1st. Yes, there had been a lot of preparation up to leading up to that date, but that doesn't mean that ICD-10 is over. In fact, it's just begun. And that means that you need to continue to make adjustments to your strategy. Nobody has ever had a perfect strategy the first day they use ICD-10 codes. It's such a large project. There will continue to be places where you need to make adjustments. And one of the big things that I hope you can do is look forward to see where some of those risks are so that you can make adjustments and prevent some of them. Well, another thing that I hope that you'll be able to do, if you've not done this already, is make sure that you understand which codes you're using. What diagnosis codes are you using most frequently? Which one of those carry the most risk? What is your unspecified rate? And how does that compare to other practices across the country? I'll share some data with you on that, share some tools that you can use in order to figure out what that is for your practice. And then you can use that data to evaluate your current process. Is my process producing the type of results that we want? Is it doing it in a way that is friendly to my physicians? And is it getting us the right code the first time? Right? So hopefully at the end of 50 minutes, you'll be able to take those things away. I hope that'll be helpful for you. So back to the beginning, why are we still talking about ICD-10? Right? October 1st for most practices came and went, and it was a non-event. So why are we still talking about ICD-10? You remember in the run-up, rewind 12 months, everybody was worried about ICD-10. It was going to be the biggest change in healthcare that we've seen in the past 30 years, right? Medicare predicted that denials would double or triple as a result of ICD-10. A lot of consultants, a lot of banks recommended getting a line of credit in place that could cover 3 to 4 months of operating expenses so that you could continue to pay the bills even if claims weren't getting paid. And for the most part, the sky didn't fall. right? ICD-10 was not a disaster for most practices. In fact, if you look at the data show that denials didn't increase at all. Let me show you this. This was published by Medicare, by CMS, 30 days into ICD-10. And what they're comparing is, here is the historical baseline. You see that on the far right, 4.6 million claims per day. Then here's what happened in October, 4.6 million claims per day. Look at the very bottom, the historical baseline, 10% denial rate. Look at the data for October 2015, 10.1% denial rate. Denials did not double or triple. In fact, they didn't move at all. Right? Everybody agreed that denials would increase because of ICD-10. That's what Medicare predicted. And then the results are very, very different. So we have to ask ourselves the question, why? Why? Why did we think that it was going to be so bad, and in fact it wasn't at all? A couple of possible explanations that we can think of. Maybe it wasn't as hard as everybody thought. Right? Maybe all of the new codes, 69,000 compared to 16,000 in ICD-9. All of the change of systems, right? Maybe that wasn't that hard. You know, maybe it was another Y2K. Everybody was worried about it, but it really wasn't that big of a deal. You know, and I don't think that's very realistic. ICD-10 was a big change, and it required a lot of planning. It required a lot of updates from vendors, right? I don't think that it was really Chicken Little, the sky was falling, and it was a non-event. Possible, but unlikely. Another explanation is maybe the provider community did a whole lot better job preparing than Medicare expected. Maybe all of the doctors spent their time last year memorizing all of the new ICD-10 codes, going to coding classes. You know, maybe the claims data that the hospitals and the providers submitted was a lot better than what Medicare had expected. Again, possible, but probably only happened in very isolated areas and wouldn't explain that the numbers didn't move across the entire industry. I think the most likely explanation is that we have not seen the full effect of ICD-10 yet, right? I'm sure that there are many people on the phone that are jumping up and down saying, wait a minute, I know exactly what it was. It was that Medicare delayed any denials because of unspecified codes. And I think you're right. I think you're right. Let's look back at what happened in 2015. The good news was that October 1st was a non-event for most organizations, right? Thursday, October 1st was not the doomsday it was feared to be. Everybody exhaled at the end of that day. The stakeholders were prepared. That's vendors, that's payers, that's the government, that is the providers, that's the hospitals, it's the revenue cycle staff. People were prepared largely. People put in the work to try to make that transition as successful as possible. And for the most part, there are some isolated areas where people had some claim problems, but for the most part, looking across the entire industry, the claims process was successful. Patient care did not suffer, and the good news was that Medicare announced that they would not deny claims because of the unspecified codes. You remember that happened in July, so just a few months before the ICD-10 conversion date, Medicare announced that via a joint press release with AMA. All right, so what was the bad news? What was the bad news from 2015? Well, I think I'm going to start with that same point. The bad news is that CMS delayed that effect of ICD-10. And why is that bad news? How could that be bad news? If I just got done saying that was good news, that really helped some people, why is that bad news also? Well, it's bad news because that is coming. That is still in our future, and many, many practices are using unspecified codes, and they're getting successful results today, right? And what that means is you can have poor workflows that are being successful, and that ingrains those bad habits, right? It's not causing you a problem, it's working, right? And so you assume that you've been successful with ICD-10 and you lose focus. You're not still watching for these types of problems, right? If claims all of a sudden doubled or tripled, right, scramble to get the team back together and make the adjustments necessary to correct the problem. In the meantime, the practice cash flow is suffering. If that would have happened on October 1st, the teams were in place, everybody was prepared and ready to make those sorts of changes, right? And the way that this was implemented, right, we've seen this from Medicare, we've seen it from the private insurers. If they slowly phase in some of those denials, it may take a while before some practices recognize that it's even happening. So that's why I would say that that's bad news as well. You know, let's look at what CMS actually said. The main point of their press release was that they would not deny claims for unspecified codes before October 1st, 2016. Right, before October 1st, 2016. This applied to Medicare only. It did not apply to Medicaid. It did not apply to the commercial carriers, so Blue Cross, United, Aetna. Now, most of those payers have followed suit. Now, are they doing that because they're generous? Probably not. I think they're doing it because they're acting out of their own financial self-interest. The payers want ICD-10 to be successful. They want to move to where they have more granular, detailed diagnosis information on those insured patient populations. They do not want ICD-10 to be another healthcare.gov, right? So they're taking the long view and saying, if we allow some grace period here, we will be able to continue moving forward with ICD-10. And that puts a lot of risk on the practices. Let me show you what I'm talking about. You remember on October 1st, right, there were all kinds of press releases and tweets from vendors saying ICD-10 has been successful, you know, pictures from their war rooms, quotes from their clients, right, saying that they had successfully transitioned to ICD-10. And there were some people calling for a little bit of patience, saying, well, let's wait and see what happens with the claim process. You know, fast forward a week and a half, and you had clearinghouses saying, we've successfully transmitted the claim data to the payer. And the payer saying, we've successfully received the claim data. Right? Victory. If something happens down the road, it's not our fault. Again, some administrators said, not so fast, my friend. We want to make sure that the reimbursement process, that we actually get those claims adjudicated and paid. So we held our breath for another few weeks, and the claims started rolling back in. And just like we saw with the data from Medicare, the majority of those claims were paid, right? So you have all the payers saying our transition was successful. The data is flowing from the providers to the payers, and the claims are being paid. And so very quickly, a lot of people turned their focus away from this, right? And you've got these other stakeholders that are saying, the plumbing is working, the pipes are all connected, but the question still remains, what is the quality of the data flowing through those pipes? And we won't know that until the payers start to deny those claims, unless you inspect the quality of the data yourself, right? And so that's why it's important to think about what ICD-10 codes you're using. So we looked at this across some of our clients in the fourth quarter of 2015 to try to figure out what codes were being used and how many of those were specific codes and how many of those were unspecified codes. Just for fun, everybody probably remembers some of the fear and lead up to ICD-10. You remember all the crazy codes that everybody liked to talk about? This was probably my favorite one, that water skis on fire, right? We looked at over 2.8 million coded diagnoses. You know how many times that diagnosis code was used? 0. It was never used. A lot of those crazy codes that people like to make fun of, they kind of got a lot of attention in the ICD-10 classes in the lead up to October 1st, were some of these crazy codes that nobody ever used. This one wasn't used ever either. But what a lot of people missed were the unspecified codes. Unspecified codes existed in ICD-9, but they're actually more common in ICD-10. They're a higher percentage of the entire code set in ICD-10 than they were in ICD-9, even though there are more codes in ICD-10. And this one is about as vague as it gets. And when we looked at the data, we found that over 40% of physicians had used this code at least once in the fourth quarter. And those claims are getting paid today. Right? Those claims, when we used unspecified codes in ICD-9, whether they were used as a catch-all or a way to save space or a way to save time on a cheat sheet, or whether they were used to make a template faster in the EHR, the unspecified codes didn't carry much risk in ICD-9. But in ICD-10, there's a short-term risk and a long-term risk to using those unspecified codes. So let me talk about both of those briefly. The short-term risk of using the unspecified codes is that the claim is going to get denied. Again, most of you are probably not seeing this today, but you probably will over the next 6 to 18 months, right? You probably will over the next 6 to 18 months as payers start to crack down on your coding. And what that means is you'll have the denials. Your accounts receivable will take longer to convert to cash, right? You'll have coders, billers that are having to research the denials. They'll have to go back and ask for additional information from the physicians. That'll take their time, not to mention the additional time required by the revenue cycle staff to nag the physician to get the data that they need. And we're already starting to see this in some payers. Georgia Medicaid is probably the largest payer where I've seen this so far, where they are starting to crack down on unspecified codes. And remember, this is new for the payers as well. So they're probably not going to all do this at the same time, and they're probably not going to do this the same way. You're probably not going to see a consistency, at least in the early stages, across the payers as far as how they're going to handle that. So that's the short-term risk. Well, what's the long-term risk? The long-term risk is that we are going to transition away from fee-for-service, right? That's at least what the government is saying right now. They want to move away from fee-for-service into that value-based reimbursement world, outcomes-based reimbursement, pay for performance, pay for quality. Call it what you want, but in that world, it is all about the expected outcome for that patient versus the actual outcome. They've got to make it risk adjusted because it's based on how sick that patient is or how sick that patient population is. And in that risk adjusted world, the way that is done is based upon the diagnosis coding, right? If you have two patients who are both equally sick, but one, you've done a very good job of coding the comorbidities and the level of specificity in the diagnosis coding, and one you've used as vague a diagnosis code as you can. The second patient does not look as sick to the payer. And we're already seeing that with the HCC codes for some of our clients that are participating in ACOs or with Medicare Advantage plans that are looking at that. If you want to protect your reimbursement in the transition to that value-based world, you need to be very careful about those unspecified codes. Okay? So how common is this? Let me share a couple of different data resources that we've used to try to get a beat on where the industry is on this. The first is from the National Institute of Health. They publish outpatient diagnosis frequency data. The most recent year that they published that data is 2014. Unfortunately, 2015 is not out yet. So 2014 data is still coded in ICD-9. And when you look at the most frequently used codes, the top 200 diagnosis codes, nearly a third of those are unspecified codes in ICD-9. Now, I mentioned that in ICD-10, the use of unspecified codes is more common. So if you take those codes and convert them into ICD-10, you get over 40% of the most commonly used codes are unspecified codes, right? So that says if you are like the majority of the population, if you're average, you may be in the 30 to 40% range of unspecified code usage, right? That's probably the high end of that spectrum. We also looked at our client data. Now, there's some sample bias in this because we looked at about 12 to 15 of our largest clients, which is just under 5,000 providers. So these are large organizations that really care about trying to code as specifically as they can. So we looked at over 2.8 million coded diagnoses in the fourth quarter, and what we found was the average unspecified rate was just over 10%. So much better than what we expected to see in the average population, but 10.7 unspecified code rate is still probably a little high. Let me try to give you some more detailed examples that might be helpful as you start to try to wrap your head around this. What are some of the unspecified codes that we're seeing used most frequently right now in ICD-10? First one is osteoarthritis. Unspecified osteoarthritis and an unspecified site, M19.90. This is one of the ones that you hear consultants talk about when they say, if you see the word unspecified twice in the description, right, that's probably a bad one that you shouldn't be using very frequently. If you look it up in the code book, you'll find 95 other osteoarthritis codes that you could be using instead, and the unspecified code is being used about 11% of the time, right? That means the other 89% of the time they're using a more specific diagnosis code. That's good, because this is unspecified as far as the type of osteoarthritis. You're not telling me if this is primary osteoarthritis or secondary osteoarthritis, or is it post-traumatic osteoarthritis, okay? You're also not telling me which joint or which laterality. So we're very unspecific here in the diagnosis. And you can see why the payers who want the more detailed information may start denying or underpaying a claim that's coded with this diagnosis code. Again, not happening today, but that's probably in the not too distant future. Let me give you another example. Malignant neoplasm of the breast, C50.919. Okay, see this used very frequently across the client base. There are other codes that are more specific. In fact, there are 54 other codes that might be better used here, because unspecified codes are being used very, very frequently, right? And I've seen this. I'll give you a story of a large practice that I heard from earlier this week, and they are actually coding this data through their EHR, and their EHR is still coding it in ICD-9. Now, I know that's hard to believe, but that's the way that they have their EHR configured. It's still coding it in ICD-9. So I asked them, well, what are you doing? You know, obviously your payers aren't paying ICD-9 codes. They said, oh, well, on the back end, we just automatically convert that into ICD-10. And if you're using something like that, 9 times out of 10, it's converting it to an unspecified code, right? That's why you see this incidence of 51% of the time for a malignant neoplasm of the breast and unspecified codes being used. That's the problem. And it's unspecified in a couple of different ways. It doesn't tell me the site. Is it the upper inner? Is it the lower inner quadrant, right? It also doesn't tell me the laterality, right? Yes, there are codes for unspecified lateralities, right? There's a code for left ear, there's a code for right ear, there's a code for unspecified ear. Same thing with shoulders and knees and hips. And those are codes you should probably never use, right? There's no such thing as a third knee, right? One more example, otitis media, right? Used all the time for primary care practices, H66.90. 80 other codes that are more specific than this one for otitis media. And the unspecified codes are being used almost 60% of the time, right? And we're not being specific here about is it chronic or is it acute, right? Is there a rupture of the eardrum or not? Which ear are we talking about? Is it the left ear? Is it the right ear? Is it both? This is the data that the payers are after. They're not denying these claims today, but that's coming in the next 6 to 18 months. Think about the workflow process of what you have going today, right? You may, the details of this probably differ from one group to the other, but from a big picture perspective, it starts with the physician encounter with the patient. That data flows to the billing team, ultimately to the practice management system, and out the door to the payer via your clearinghouse, right? Again, the data is flowing successfully today. What is the quality of the data flowing through that process? Because if it's not good, when the payers start to deny those claims, you're going to end up in this routine back at the beginning of the process where the billing team is having to slow down and the billing team is having to go back to the doctor. The doctors have to answer those questions that they don't really care to answer. And our cash flow is taking longer for us to collect. Those are bad outcomes all the way across the board, right? And when you look at, there are 2 studies that I'll share with you that were done trying to quantify what is this risk, what is this cost, and what does that look like for the physician practice. The first is a study that was done by Nachemson Advisors. Stanley Nachemson is the principal of that group, very well respected in the healthcare world. And what they did was they tried to estimate the cost for a practice to transition to ICD-10. And they separated it out by small practices, medium, and large. Small were 3 providers, medium was 10 providers, large practices were 100 providers. So let's look at the medium practice. And you can see that they broke out those costs into pre-implementation cost and post-implementation costs. The pre-implementation costs are behind us, right? You've already done that. The post-implementation costs, right? Those are still ahead of us. Those are still ahead of us. We have not seen the impact of ICD-10 yet on productivity losses or payment disruption, right? It's not that we've dodged the bullet on that. It's that it hasn't arrived yet. And the productivity loss, quite simply, is once you lose that time, you never get it back. You can never get those dollars back. The payment disruption, yes, you can mitigate some of that risk with a line of credit, but we'd rather prevent that payment disruption loss or do everything that you can to make sure that you're on the low end of that spectrum rather than on the high end, right? The way that they calculated this was, again, going back to the payers, saying, what do you expect to see? They expect denials to double or triple, right? And the part that makes this tricky is you won't see that all at once, right? If you saw a payment disruption of $100,000, you would notice it if that happened in one day. But how long would it take to notice if it slowly trickled in, right? If that was spread out over a long period of time, it's a much harder thing to notice. Another study that was done by the advisory board, they looked at Canada's transition to ICD-10 and said, what should we expect to see from a productivity loss here in the United States? You look at what they put front and center, and it's physician productivity. Physician productivity decline of 10 to 20%, right? And that may be okay in a country like Canada where most of the physicians are government employees, but that won't work here in the United States. Our doctors are not government employees. Our doctors are small business owners. In a fee-for-service world, they're paid off their time. They're paid off their productivity. You want to get underneath these numbers a little bit more, understand what was happening? You had coders, you had billers going back to the doctor, asking follow-up questions. I need you to be more specific here. Tell me more about the disease type, right? Was this acute or chronic otitis media? Which ear was it in? right? And that back and forth takes time. This study estimated that it would be 45 to 90 minutes per provider per day. Even if you cut that in half, I think that's unacceptable. For a busy private practice, your doctors don't have another 22 to 45 minutes per day. How are they going to do that? Are they going to see fewer patients, longer office hours, spend more time away from their families? None of those are good outcomes. None of those are good outcomes. We have to protect against that and get ahead of this risk so that you can minimize it for your doctors and for your practice. And the coder productivity, you would expect there going to be some decline in their productivity as we continue to have to be more specific in ICD-10. They will get up that learning curve, but that learning curve may be longer than originally anticipated because of the delay in the denials for the unspecified codes. And then on the far right of the screen, you see the rework productivity. That's simply the increase in denials, rejections, rework from the payers. It's going to take more time to go through and do that. So how do you tie that together? How do you know what the risk might be for your practice? Well, the way that I would recommend doing that is looking at what that unspecified rate is for your organization. I'll show you with this slide. We're trying to do here is say, okay, let's assume for a 10 provider practice, an unspecified rate of 10%. Okay, so you've got 10 providers, each one seeing 30 patients a day, 3 diagnoses per encounter. That's a total of 900 diagnoses per day. 10% unspecified rate would lead to 90 potential denials per day. Okay, just trying to look at a specific use case, right? So that's 90 potential denials per day. If they're evenly distributed across your doctors, that's 9 potential denials per doctor. 9 potential questions back to the doctor per day. If each of those questions takes 3 minutes to read and research and respond for the physician, that's a total of 27 minutes per doctor per day answering coding-related questions. So you can see very quickly you can get into that range mentioned in the previous study. And if you try to use the medical economics figure of how much does a denied claim cost a practice, medical economics uses the figure of $25 per denial, right? The cash flow risk for a 10 provider practice with a 10% unspecified rate would be just over $2,000 per day. Now again, if all of a sudden tomorrow your doctor started spending 27 minutes per day answering coding questions, you'd know about it, right? And you'd do something about it. The problem is all of the payers are not going to do this on the same schedule, and they're probably not going to start denying everything all in one day. So you may see this slowly phased in over time, and it may take a while for you to notice what's happening. It's I heard somebody once talk about how you boil a frog. Anybody else heard this before? How you boil a frog? If you put a frog in a pot of boiling water, he jumps out. Instead, if you put a frog in a pot of warm water and slowly turn up the temperature, he doesn't notice the difference until it's too late. And I think for some practices who have turned their focus off of ICD-10 because there are plenty of other things that you need to accomplish in your organization, and the way the payers are phasing this in, it may go undetected, right, until the problem has grown to much larger than you'd want it to be. So I think what the best things you can do for 2016 is to ask yourself and identify how at risk is my practice. What is our unspecified rate? Are we doing pretty good on this with room to improve? Or do we need to start working on this immediately? And then, once you're armed with that data, then looking at your processes and saying, how is my process doing? Are we doing a good job of protecting our doctors? Are we doing a good job of generating the right type of data we need to get the claims paid? Where do we need to make adjustments? Because right now, the good news is you still have time to make those adjustments. Make those changes before it's too late. Be proactive here instead of reactive. So if you don't know what your unspecified rate is, I would certainly recommend doing this. It's called Unspecified ICD-10 analysis. We've done this for our clients. We are happy to do this as a free service for anybody who attends one of our webinars. So if you would like this done, all you need to do is let us know in the questions panel. I'll have somebody follow up with you, and we'll do this analysis for you. And what we'll send you will give you your unspecified rate for your practice and let you compare that to the national average so that you can see how at risk your practice might be. And then you also, at the bottom of this screen, you see the detail on a per provider basis. It gives you your rank, right? So that you can see that Dr. Jefferson down there, he's bringing up the rear. He has an unspecified rate of about 17%, almost twice the average for this particular practice. And Andrew Jackson is leading the charge. He's at 2.7%. Now, I usually get questions here asking me about that unspecified rate and saying, are you ever going to get that number down to 0? And I'm sure many of you already know the answer to that. The answer is no. You're never going to get that down to 0, right? There are times when you should use unspecified codes. There are times when you can use unspecified codes correctly. Let me give you a quick example. A pediatric client of mine in Georgia, so they have some Medicaid patients, and Georgia Medicaid is one of the payers who's already doing this. They're already cracking down on unspecified codes. Georgia Medicaid has gone too far. They are denying everything that is an unspecified code. So when a patient comes in to this pediatric clinic and they are using a code for an unspecified fever, right? Patient has a fever. Parents bring them in. That says, you know what, this is viral. You just need to go home and rest and drink plenty of fluids, and you'll feel better in a few days. We don't need to go to the hospital. Don't need to be admitted. The right code for that is an unspecified fever. We don't know what's causing the fever, and it doesn't make sense to do the tests required to understand what is causing the fever. And Medicaid shouldn't be denying that. It doesn't make any sense to run those additional tests to try to get the claim paid, right? So that's where you've got to remember the payers have not done this before either. They are new to this. They are going to make mistakes, and you need to know what codes you're using, which unspecified codes are probably okay, which ones are not, so that when they deny a claim like that, you can argue with them, and you can make sure that you get that claim paid correctly. Because it's not really just about that one claim. It's about that that's going to happen over and over and over again, so that you can make sure that you get that paid correctly going forward. Now, another part of what we'll do with this unspecified analysis is we'll also show you your top 10 most frequently used unspecified codes. Here's the unspecified code. Here's how many times you used it. And here are the more specific code alternatives that you should consider. Right? Obviously, a code like this, pain in an unspecified shoulder, there's no such thing as an unspecified shoulder. You really shouldn't ever use that code. You should always use the more specific codes for pain in the right shoulder or pain in the left shoulder. So I think this is a helpful place to start, to know what your risk is and to know what the more specific codes that you should be using are. You can share this data with your providers. You can share this data with your colleagues so that you're not surprised when you start seeing the denials and so that you can do something about it. Let's start with the ones you're using most frequently and then work from there. right? And then once you know the data, then you've got to ask yourself, okay, what does our process look like? Is it generating the type of results that we want? I've seen clients handle this several different ways. Some practices, not as many with option number one, but try to hire certified coders. So we're going to code every single encounter from every single note, right? Problem with that is in the outpatient world, it's a bit too expensive to really try to do that for most organizations because the reimbursement levels are flat at best. You've got coders getting more expensive and they're getting less productive. From an ROI perspective, that's really a double whammy, right? So I don't see a lot of people do that. Now, I do see a lot of practices that are doing this through their EHR. The thing that you've got to be careful about there is oftentimes the providers will complain that it takes too many clicks. And so what they're doing is when they do their code search, right, they search for osteoarthritis and they get 95 search results. They're not taking the time to read through all of those search results. They're not taking the time to drill down to the right code for that patient encounter, right? We've been trained by Google to expect one of the top 2 choices to be what you're looking for. And so you've got to be careful about, if you're doing that, how your EHR is handling that. Some do it very well, some do it very poorly. What really matters is how are your doctors actually using the application? Because oftentimes they are picking unspecified codes instead of going all the way through to the end. And I'll show you kind of 2 different ways of displaying the same data, and you'll see why it makes a difference. Another thing that I've seen some groups do are cheat sheets or a crosswalking tool or an encounter form, and these are these are tempting alternatives. They're tempting because a lot of times they do work right now, right? They're not causing denials. It's fast for the clinical staff. It's very little change. But what we've seen for these people is it's a very high rate of unspecified codes. They're setting themselves up for failure when the payers start to crack down on these claims. Obviously, some of our clients, we think they're doing a very good job with this, with the electronic super bill of Excel Capture. The doctors really like it, but it also gives the billing team the more specific code, and you can see that in the data that the unspecified rate's much lower for those clients. So 2 different ways of displaying the same data. It's why it matters how your application handles this. Here's just a straight code search example. I type in osteoarthritis and I see the search results. You can see they're all listed there. I can scroll down and find what I'm looking for. The problem is over half of the time when a doctor is coding osteoarthritis, it's of the knee. Sometimes it's left knee, sometimes it's right knee, sometimes it's both knees, but it's in the knee. And the problem is you'd have to scroll down over halfway down this list to find what you're looking for. Or you'd have to use additional clicks on the left-hand side to drill down to the knee and the proper laterality. So another way of organizing that, right, is through what we call a custom scenario. And you can see that it's organized to show the knee codes first. You could change away from that if you need to. It doesn't list the choice for unspecified knee. That's been removed, right, because there's no such thing as a third knee. And it organizes it in a way that minimizes the amount of time and mental horsepower that the doctor, the clinician, has to spend to recognize what the choices are and minimize the number of clicks to select the right code. All right, another example. This was another unspecified code that we talked about before, malignant neoplasm of the breast. Again, I can do the search. I can see all the search results. The problem here is that half of these search results are for male patients. And over 99% of the time that you're coding for a malignant neoplasm of the breast, it's for a female, right? And I've got to do a lot of reading or a lot of drilling down to get to the right location and get to the right laterality. Again, a way that our clients have handled that is to hide the male results. I can flip to that if I need to, but 99% of the time it's going to be for a female patient. And then I'm going to organize it by laterality across that horizontal axis with the location on the vertical axis. Again, making that very easy to see what my choices are and making it easy to make the selection. This particular group, they also wanted to add in the estrogen receptor status. So you can see the second required code at the bottom, is that positive or is that negative, adding in the Z code. Making sure that they're coding as accurately as they can. Last example, otitis media. Again, we talked about this. Over 60% of the time, an unspecified code is being used. Make this easy for your doctors. Don't make them read through all the choices. Don't make them drill down. Sort it in a way that shows them here are the acute options, here are the chronic options, here are the laterality options. Make it easy for your doctors. Now, we spend a lot of time talking about the doctors because we do need to make sure we protect their time. But let me spend the last few minutes here talking about the revenue cycle team, because it's a big change to revenue cycle departments as well, right? You think about ICD-10 from a very high perspective. You know, we get paid for CPT codes. You've got to have a diagnosis code that makes it medically necessary. We're still in the fee-for-service world. That was true in ICD-9. That continues to be true in ICD-10. If only the billing were that easy. Because you still play this cat and mouse game with the payers, right? You have to jump through their hoops and hurdles to make sure that the claim gets paid correctly. And not each payer handles that a little bit differently, right? Medicare wants it one way, Blue Cross wants it another way. We've dealt with that for years, right? In ICD-9, we use ICD-9 for over 30 years. The requirements change from month to month, from quarter to quarter, right? But for the most part, everybody understood the ins and outs of that game. The problem is, if you had that knowledge stored in someone's head, if you had that knowledge stored in a binder, that knowledge went out the door on the night of October 1st, right? You had this big one-day event, but we're not seeing the full effect of it yet. We will. That's coming. So it wasn't just a one-day change for the billing team, right? We're going to see changes over the next 3, 6, 12, 18 months as the payers continue to make changes to their adjudication algorithms. They're going to change that cat and mouse game. And they're not all going to do it the same way. Because remember, the payers haven't done this before either. They're learning as they go. They're analyzing all of the claims data that they're receiving. And they'll be making changes to their adjudication process as a result. And what that means is the rate of change is going to be much higher than anything we've seen before in our careers, right? The rate of change is going to be much higher than anything we've seen before in our careers. So you have to ask yourself, if that's what the new world is going to look like, how is my practice going to manage that? What types of tools, what types of processes do we need in place to manage that? Who on my staff is going to manage that? And maybe the scarier question is, what happens if we don't? What happens if we don't do a good job of that? And so what I would recommend doing is looking for those places and making sure you've got a process in place to handle this high rate of change. Again, you can do this in somebody's head. You can do this on a notebook. You can use software to do it. What we recommend is a process called closed-loop denial prevention. And what that basically means is, when I can't rid the world of denials. There are always going to be new denials. There are always going to be new policies from the payers. But when I see that, when that happens, I'm going to go back to the beginning. I'm going to figure out what went wrong. What could we have done to prevent that denial? And I'm going to build in a new rule. I'm going to build in a new rule to make sure the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the same way for every single employee every single time, right? I don't have to rely on everybody having a perfect memory every single time. if I can put a tool in their hands that helps them do that, it gives me the same actionable information, whether it's my most senior certified coder or my newest billing clerk. That helps me prevent denials. That helps me protect our reimbursement, right? Share one example with you we saw from a client where they had a payer that started not denying a claim, but they started paying them a reduced reimbursement rate because of that unspecified code, right? So that's not showing up on a denial report, much harder to detect. So what they did was they built in a rule that says when I see a patient that has that unspecified osteoarthritis code, unspecified knee, give me an error message like you see in the bottom left-hand corner that says, hey, this payer pays us a reduced rate when you use that unspecified code. So I can catch it, I can correct it, and the claim goes out cleanly the first time, so I get my complete reimbursement. Again, a lot of different ways to skin that cat, but make sure that you're thinking about that. Make sure that your organization is prepared for those changes that are coming in 2016. I know I've gone through a lot of information, but hopefully you can take some of these points away with you and help make your organization better. ICD-10 has only just begun. You're going to need to continue to look for the potential problems and make adjustments in your strategy, in your workflows, in your processes to make sure that they work the way that you want them to. One of the best things that I would recommend doing is doing the unspecified analysis, understanding what your risk level is and what you can do to reduce it. And reduce it in a way, obviously, that protects your doctor's time, and make sure that you get the right code the first time so that you don't have all of that back and forth between the provider and the billing staff. Thank you so much for your time. Let me try to cover as many of the questions as I can before we run out of time. I want to make sure that we are respectful of everybody's time. Okay, let's take a look here. Yes, okay, for those of you who want a copy of the slides, who want to link to the recorded version, we'll email those out. Just let us know in the questions section, and we will send those to you. So those of you who have already asked for it, we'll make sure that we get that to you. The unspecified analysis, somebody asked a question on that. How do you do that? What do we need to do if you want that done for your practice? If you want the unspecified analysis done, just put it in the questions panel, and I'll have somebody reach out to you to get the data that we need. Basically what we're looking for is each diagnosis code by provider, how many times it was used. You can usually pull that report from your billing system, and that way we can import it and we'll get the results back to you. It usually takes us a couple of days to run that after a webinar, because there are usually people that want that done. So we're happy to do that. And somebody asked a question on this. There's no charge for the unspecified analysis. If you attended one of our webinars, we do that at no charge for you. So if that's helpful for you, feel free to ask for it. Somebody asked a question again on the payers. When do you expect that the private payers will start to crack down on this? It's tough to know. We've seen Georgia Medicaid do that already, a payer in Texas, a payer in Arizona that have done that already. It's one of those things that you don't know when they're going to do it, and you don't know how they're going to do it. Georgia Medicaid did that. In my opinion, they went too far. They did it for all unspecified codes. Some payers may take that approach. Others may look at their data and start to crack down on the ones that are being most frequently used. So we're still in a wait-and-see mode on that. Unfortunately, you probably don't get a lot of warning from the payers as far as when they're going to do that. Somebody asked a question, is Medicare for sure going to start that on October 1st, 2016? Great question. I don't know. The way that they worded their language, and it was just in a press release, it wasn't legislation or anything like that, or an official rule. They said that they would not do that before October 1st. So if I'm trying to read between the lines, it says that they are not required to do that on October 1st. they may do it, but they're not required to. So I think that's the tricky part. You know, I could easily see them pushing that back again. Part of it may depend on the quality of data that they're getting. You know, if they look out there and see that they're not getting the specified codes that they would like to get, they may push on that harder than they otherwise would. So I think that's a great question that you're asking, but we're still in a wait-and-see mode as far as how they're going to handle that, what they're going to do. I mean, just to add another level of intrigue, that October 1st date would be just about 30 days before the presidential election. I don't know how you factor in that, but surely those people will be thinking about that as well. So, you know, interesting points all around. Got a couple of people that have given me some feedback on the presentation. Thank you very much for that. That's supremely helpful. We'll be doing this webinar again and love to make it better. So if you've got any feedback for me as the presenter, or if you've got any feedback on the content, what you loved, what you hated, certainly would appreciate that. So thank you. I think I've covered all of the questions that I've seen. If there are any that I missed, we'll make sure we follow up on those one-on-one. I'll leave the questions panel up for a few extra minutes in case there are any additional requests for slides, unspecified analysis, link to the recorded version, or any other feedback for me. So thanks so much. I hope you have a great rest of your Thursday, and we'll talk soon. Bye-bye.